Good afternoon and welcome everyone. I'm Jennifer Haley. I'm a researcher in the Urban Institute's Health Policy Center. We're so glad you could join us today. Before we start, I'll go through some very quick housekeeping. The event is being recorded and the recording will be posted online afterward. Speaker biographies are available online at urban.org and a link to the bios will be posted in the chat. All participants are muted, but you can send questions or comments in the Q&A box at any time, and we are reserving some time at the end for audience Q&A. Captions may be turned off using the live transcript button below. A post-event survey will be posted in the chat. And finally, if you tweet about the event, please use the hashtag #LiveAtUrban. We're really excited that you're joining us today and looking forward to diving into our discussion, leveraging community expertise to advance health equity. We're going to hear from a great panel who will be talking about the value of collaborating with communities in efforts to promote greater health equity and sharing some strategies on how to learn what a community wants and needs and how to overcome common obstacles. We'll then hear from Amy Tawarson from the National Academy for State Health Policy to get her take on what policy changes and resources are needed to lead us to more inclusive and sustainable progress toward health equity. And then, as I said, we'll conclude with some audience Q&A. But first, to kick us off, I'm very happy that we're joined today by Mona Shaw, Senior Program Officer at the Robert Wood Johnson Foundation, which supported the research that gave rise to this event and that's supporting the event today. As a researcher and an expert in health policy, she's involved in the process of understanding and measuring key health and healthcare issues essential to the Foundation's strategy to move our nation toward a culture of health. So Mona, I'll turn it over to you now.
Thank you, Jennifer. Good afternoon, everyone. In the past 2 years, we've seen governments, private organizations, and funders and others lift up the importance of addressing health and racial inequities. To meaningfully achieve health and racial equity will require us to share resources and decision-making power. Racial justice in the United States will take all of us working together, but how we work together matters. To meaningfully achieve equity means moving beyond simply seeking community input to truly collaborating and help build powers of communities. We can't just ask communities to identify priorities, but we must work alongside community organizations and community experts to ensure we're working on a long-term solution that can ultimately reduce inequities. But what are ways we can do this? Jennifer mentioned Urban Institute research that was just published. The research found that effective community engagement requires working around 4 guiding principles. The first is establishing trust among all parties involved. The second is ensuring flexible and sustainable financial resources are available. The third is committing to continuous and sustained relationships, which requires considerable investments of time as well as follow-through. And fourth, paying explicit attention to eliminating structural racism, both within and outside of government and organizations. And during this event today, we'll be hearing from experts in the field on ways to implement these 4 principles. I want to thank the Urban Institute team who worked so hard to put this event together. And I also wanted to thank the experts who are listening in and participating for lending their time and being part of this important conversation. I'm going to turn it over to Eva Allen, who will moderate the panel discussion. Thank you so much.
Thank you, Mona. Good afternoon, everyone. I would like to invite our panelists to join me on screen now. It's very exciting to welcome 3 fantastic panelists who bring in a range of perspectives and experiences with engaging community members and building community power. They are Dr. June Gibson, President and CEO of My Brother's Keeper in Jackson, Mississippi. My Brother's Keeper is a community-based organization dedicated to serving people with HIV/AIDS, the uninsured and underinsured, and other marginalized groups, and addressing health inequities through health education, health promotion, policy and systems change, and other health equity approaches. Next, we have with us Deb Golding, Lead Project Officer for the Health Equity Zones Initiative in the Rhode Island Department of Health's Health Equity Institute. DEB supports the mission of the health equity zones to establish community-led collaboratives to develop into equity-driven, self-sustaining and self-funding entities that can respond to evolving community needs and priorities with the ultimate goal of addressing the social determinants of health. And we also have the pleasure of being joined by Maggie Gomez, Colorado State Director at the State Innovation Exchange. Maggie has nearly 2 decades of community organizing experience, working on health and racial equity issues for immigrants and people of color in Colorado. Welcome. And I would like to direct my first question to you, Maggie. From your experience as a grassroots community organizer, why do you think it's important to engage people from marginalized communities in efforts to advance health equity?
Thanks, Eva. If our goals as advocates, practitioners, and researchers is to truly improve the health outcomes and holistic well-being of people and communities who are outliving a very targeted and well-resourced effort to reduce their social, economic, and political power, then it's imperative that we work together with people who experience systemic barriers such as racism. Engaging communities who are marginalized is a really effective approach to better understand how these systemic hurdles show up in their lives and to better understand the nuances and how they operate. In order to reach these goals, what better way to solve the problems and get closer to addressing those root causes than working with those who are facing those issues every single day? People in communities who are directly impacted by racism, sexism, classism, etc., intimately understand how those systems operate and are best suited to have solutions for those unique community challenges. Coming up with creative solutions that connect with and among the people is another way that solutions can be the most impactful and achieve the intended outcomes while minimizing or eliminating unintended negative outcomes. When governments or community organizations or outside institutions don't take these approaches to co-creating solutions with the community, it quickly and easily comes across as outsiders trying to parachute into a place who think they know more or maybe even better than the people who live there and are coming in to take over and impose their own will and ideologies. And historically, this has shown up as violence, specifically for Indigenous communities and communities of color. It feels like colonialism in the modern day.
Thank you, Maggie. And can you elaborate on how community engagement is different from traditional stakeholder outreach?
Definitely. Things like surveys, interviews, focus groups are all exercises in stakeholder outreach, but they often come across and are actually extractive. The government or researcher comes in and takes information without giving it back to the people they gained it from or sharing what they did with the information. And yet the organization, entity, or practitioner could not do their work effectively without it. These tactics may feel like they take less time or resources, but cutting corners and taking shortcuts are no way to uncover the best solutions. And that's what true community engagement is seeking to do. Instead of replicating systems that value quantity over quality, either or thinking or objectivity, deep community engagement strategies require really taking the time to build relationships, earn trust, and actually share power throughout the process. And this is how we'll co-create the solutions to deeply entrenched inequities. The outcome doesn't just come at the end of a project, but the outcomes of deeper relationships is built into the process itself.
I love that. Thank you, Maggie. June, I want to turn to you. Something that Maggie just pointed out is really building community power as being one of the core components of engaging our communities. In your experience as a CEO of a community-based organization, what does it mean to you to share power with communities, and how can it be accomplished? And could you please unmute yourself?
When I think about shared power, I pretty much take it from the exact wording. And it is basically someone who has the power, and that could be the finance, the organization, who actively wants to share with the community. It's not a passive thing. It's an active approach to including the community into the work that you're doing and making sure that you're doing the right thing for the right group of people. Now, I do not believe it's an easy process for most organizations or for the community. In particular with the organizations, they have to see the community as actually having a voice. They have to see the community as being valuable, as someone who can actually, pretty much tell them what to do, who can say, this is the right approach, this is the wrong approach. And I think for some organizations or entities, that's just not what they want to do. For so long, historically, as Maggie was saying, there has been this notion, this rule that I know what's better for you, that I can give you what you need, that you really don't know what you need. And this is what we have to offer, and you have to take it. And that's a terrible approach to take with the community, unless you just don't want to get it right. If you just want to say that I did it, then that's the best approach. But if you want to get it right, you have to invite them into the process. But even on the community's end, they have to see it as a benefit. You can't decide that this is a benefit for them just because they may be suffering from something, or they may be impacted by something. They have to identify that as something that's actually a part of their life that they want to change. And doesn't always happen for no other reason. I mean, mind you, the community needs their skills built. They need to be able to articulate themselves in the process. And if they can't do this, they can't tell you exactly what you need, then you're checking a box. You're able to say, I had a meeting with the community and the community said this, but it wasn't really anything that you could use. It wasn't effective. So to make it happen, you have to build their skills to be able to tell you what to do. And again, most organizations don't want to be told what to do. I think if you move through this process and you really consider sharing power, you build skills. You invite them to the process, not just at the very beginning or not just at the very end. It's an ongoing thing that you have to do. And I think most importantly, trust. And trust isn't easy. It takes time to build trust. And so if you go into a process thinking that just because you build it, they're going to come, you're going to be sadly mistaken. It's going to take time, and there's actually nothing wrong with that. Behavior didn't happen overnight, and it's not going to be cured overnight. And so it takes us sitting and talking and understanding that the community is going to change, and we have to be willing and flexible to change with them. But their ideas matter. Their ideas are important. And if you really hone in on what they're asking you to do and telling you what to do, you can have a very successful program and a very successful organization.
Thank you, June. I would like to reflect on something that one of our Urban's own community engagement experts, Elsa Falkenberger, often says, that for authentic and meaningful community engagement, we have to look inwards and backwards. Inwards and how we need to change our own practices, our own institutions, and backwards to understand the history, so that our work is fully grounded in what communities have experienced, where their hesitations come from, and what we need to, or why we need to shift away from our traditional stakeholder outreach. Some of the things that you've mentioned throughout, June. That Rhode Island, with its Health Equity Zones initiative, is moving in this direction and has taken steps to not only invite community to provide input, but asking the community to develop and implement solutions to the challenges that they're experiencing. Could you give us a brief overview of the Health Equity Zones initiative, and then talk about how you are able to achieve that culture change and buy-in within the Department of Health to implement more effective engagement of communities in your health equity work?
Sure, thank you. I'm really honored to be here on behalf of everybody in Rhode Island who's doing this work. I get teased a lot because everybody says I should be wearing a t-shirt that says work in progress, because like June said, this is a work in progress. The health department launched the Health Equity Zone, or HEZ initiative, as we call it, back in 2015, with really 4 key components to successful and sustainable implementation of the model. HEZs, the Health Equity Zones, must be equity centered, with health equity as the primary goal setting and parameter and evaluation parameter for the work. HEZs must also be place-based. They are defined as contiguous geographic areas with a population of at least 5,000 people. HEZs are strong, community-led. So a strong community strong community serving organization serves as the backbone, and it convenes, facilitates, and maintains a collaborative which is representative of the community to engage the community in a local comprehensive community health assessment that tells the story of the needs and assets of the community. And we know that there's a lot of existing data, but like Maggie shared, it's important to emphasize that people who receive services and community organizations who operate on shoestring budgets are often survey weary. They don't see the results of the survey, and they often don't feel heard. So what's unique to the HES initiative is that this is done with the community. The community identifies the issues that emerge from their assessment process, determine which issues are priorities, and develop and implement a plan of action focused on addressing the needs of the communities, those social determinants of health. So to look inwards and backwards on how we got there, what prompted this shift, it really is a strong, committed leadership at the health department that really recognized people were experts in their own lives. It's why I'm at the health department. I come to the health department as an advocate, as a parent, and the health department really understands that they need to bring people into state government and state government to the lives of the people. That leadership understands that place matters, that despite all the money that we invest in healthcare, in clinical settings, 80% of health outcomes are determined by where we live. We understood that we've overinvested in healthcare and underinvested in public health for many decades. And with the support of the strong, committed staff from some of the programs at RIDO, who really championed with the community environmental, social, environmental, and racial movements like SOGI, racial equity, police reform, disability rights, behavioral health, and the effects of climate change, galvanized this real shared understanding at the department that we need to do some collective action. So the health department formed a Health Equity Institute. The HES initiative was launched. This is all back in 2015. We had a new director, Dr. Nicole Alexander Scott, who elevated the department's priorities to address social, economic, and environmental concerns regarding health, eliminate health disparities, and promote health equity in the department and in Rhode Island, and access to quality services for all Rhode Islanders, including the most vulnerable. So all of this really promoted the HES infrastructure to help lead this effort. RIDO recognized that the focus of our investments really needed to shift to invest in building community capacity so we could move the needle to affect outcomes. And so that with this new approach, we needed to align a diverse set of federal and state and local and private resources to help the community in this capacity. And so from the launch of the HES in 2015, Rhode Island now has 15 health equity zones serving approximately 85% of the population of the state.
This is amazing. Something I'd like to follow up on is this idea of place-based initiative. Can you talk about why it's important to have this local level structure as opposed to a statewide initiative, and maybe give us some examples of some of the priorities that different communities have selected?
Sure. So most people know Rhode Island is very small. It's the size of a large city with just over 1 million people. Feels really big to us. It's divided into 39 incorporated municipalities with 8 cities and 31 towns. This is where the stories and the narratives from the community are making a difference in changing culture, because every community is unique with different demographic makeups, histories, and cultures. The local approach is important to the HES model, as each community has assets and resources to bring to the table. While there may be some unifying challenges across HES communities, each has a different relationship to those issues. For example, the Newport Health Equity Zone has identified civic engagement and voter registration as an overarching goal to impact the social determinants of health. So a lot of people may be familiar with Newport, Rhode Island, its mansions, its international boating festivals, music festivals. It's a real tourist destination, but there's the north end of Newport, which is often overlooked. It's a racially diverse community with the highest concentration of poverty in the city. It has a vibrant community center, community-based organizations, including the backbone organization, which is the Women's Resource Center. That really makes up the HES. So in addition to facing the challenges of poverty, there's a significant geographical barrier that separates these two Newports, and a major economic development project underway that's sure to develop and benefit the tourism industry and all that, but it really had potential to threaten the north end of Newport. So here's where the work of the HES highlights the issues of wealth and poverty and development and gentrification and climate change and environmental justice and even domestic violence and health equity have merged into a single conversation. And because the Newport HES had intentionally engaged residents to be part of these of government, actually took them to meetings and showed them how to be part of government, the residents were prepared to voice their concerns at those conversations and were actually asked by the city to be part of those conversations. We also have the Central Providence HES, who has workforce development as an overarching area to focus social determinants of health. And really what's driving their story are the two sides of Providence. There's the one side of Providence that's more affluent, and then there's the side of Providence where the health equity zones are, including the Central Providence HES, where life expectancy is about 9 years less for residents living on that side. And so one of the ways that the Central Providence Health Equity Zone is addressing this is by hiring, increasing economic development by hiring community health workers in the area to help with systems navigation, and then also to really build the skills of the people of the community and focus on childcare and all this. And then finally, I just want to say, you know, looking at health outcomes from a statewide level can make it easy to miss the nuances of all these little distinct local histories and experiences, and that the data, again, does not tell the true story and can often be stigmatizing to these communities. We have two communities, West Warwick and Woonsocket, who were both post-industrial mill era communities that were left abandoned really and struggling once that infrastructure left. The data here in West Warwick doesn't necessarily tell the true story, because West Warwick has chosen to address issues facing the community head on, including poverty, homelessness, and the opioid epidemic. It found strength in its collaborative through its paid resident advisors, the collaborative representation with the police department, the local health center, the school department, the fire department, all coming together to make West Warwick a trauma-informed community. And so that is helping to, you know, sort of change that perception of this a community with a lot of opioid issues. Also, the Woonsocket HES, like I said, was another post-industrial city. It's investing in sex education and racial equity in the high school to counter the often data-driven misperceptions of their community. So this work has forced the state to recognize that aggregate data only tells part of the story, and that state level decision makers are not in a position to determine local priorities and identify solutions alone. It's a partnership effort where the community is best positioned to lead.
Thank you, Deb. And I love how really different, you know, from what we just heard, different communities experience different issues and have different concerns, and really it's important to understand that story behind. And that's a great segue to my next question for June. You know, from the HES work, community needs assessment and getting to know the communities has been essential to building the health equity zones. And when we talked to you earlier this year, June, you mentioned that your organization, My Brother's Keeper, is really intentional and works really hard to ensure that your programming and services are responsive to what the community needs. Can you talk about some of the ways in which you go about learning what the community wants, needs, and preferences are?
Yes. So of course we do formal and informal processes, which includes focus groups, surveys, key informant interviews, and we utilize that information within our projects to make sure that we pilot the right marketing materials, or we actually implement the right marketing materials. And that's pretty much the formative evaluations that we put in our projects. But we like to take a little further. We actually hire from the community, and in multiple ways. We do a lot of internship programs, and internship programs can include college students, but we also have AmeriCorps. We also have LGBT interns. These individuals may have just finished high school. So we take in interns and we give them training, we give them phlebotomy skills, we teach them outreach, we teach them different things that we do. And we like to hire the people that we have invested that time into. So if you've interned with us for 10 weeks, I think we've taught you a little something and we should be able to keep you. We should be able to do something next with you. And so we hire them and we incorporate them into the organization. And that does a couple of different things for us. First, we find out change on the ground. So this is like our real time. You know, when you do the focus group, that's at the very beginning. Time goes by. You have a complete year that goes by and you may never hear anything else. But if you have someone who's representative of the community, that person is going to see change happening in real time. And they can tell you what's happening, they can articulate that to you. And so now you get to actually change or be flexible based on what's actually happening, not what happened 12 months ago when you wrote the grant, but what's actually happening on the ground today. And so that strengthens us. We're linked to the community in just, it's sometimes unreal. And mind you, you don't always get the answers that you want. I mean, things can go wrong. They may be mad. We've done something that was offensive, but now we have to change it. And it's like, well, why do we have to keep changing every time they get mad? Because they're mad. That's why we have to change. And there's nothing wrong with that. We just mold, we become more flexible. Also with the individuals that we hire, we try to do a better job at not just keeping them as community health workers or outreach workers or lay people. I want the community voice throughout the entire organization. This is from finance, to the doctors, the nurses. I want the people who can get to the table, the people who will be heard, the people who will be respected. I want them to have the education and the skills and the certifications to get to the table, to be able to tell them what's happening in the community. So, because we know the world in which we live in, you don't get the necessary respect that you want if you don't have the credentials that go along with it. So we actively invest in the staff to make sure that they can get credentials, that they can be the person that they call from My Brother's Keeper. They don't always have to call me. Literally, you can call any of my staff and they can come to the table and explain themselves very well and tell you what needs to happen next. They are very versed in multiple things. I mean, they may start out as an outreach worker and move to billing. They may be in billing and move to case management. You know, now they want to be nurses. And so I'm really proud to say that when it comes to how you get information, I like to say that I invest in getting information. I make sure that I give something back to the people who are ensuring that the community that we work in, that they can actually thrive. And it has worked for us for quite a while now.
Well, this is amazing. And from when we spoke earlier, you mentioned this, that your organization has really grown from just focusing on HIV/AIDS to including other health conditions, chronic health conditions like diabetes and hypertension, but then also including new services to build capacity of not just your staff, but other CBOs, for example, in research and evaluation or fiscal management. So what prompted this expansion and how were you able to achieve it?
Well, we work a lot in HIV. And when PrEP came along, the pill that prevents HIV, it was a game changer for the organizations that we work with. The individuals who do HIV prevention, you were accustomed to passing out condoms. That just wasn't going to be enough anymore. And so we saw the writing on the wall that there was a medical model coming and that we had to either become a clinic or become great friends with the clinic. But there was no way that you were going to be able to survive this if you didn't incorporate all mechanisms that can prevent HIV, which spills over into STDs and reproductive health and all these other issues and isms that happen. So we knew we had to make a change. So the very first thing we did, again, with surveys, which was very beneficial, we host Jackson Black Pride every year. And so we did a survey at Pride and we asked the question, if we were to open an LGBT clinic, would you come? And if you would come, what color should it be? What name? What services? Do you have insurance? Can you get insurance? We asked all the questions. And so from that survey, they gave different terms like open heart, open this, open that. And that's how we came with open arms. The colors are the exact colors that they picked. So as Maggie was saying, if you can see the information that someone's gathered from you, if you can see it in real life. So we took what they gave us and we turned it into an actual clinic. And from there it grew because they also told us what services they wanted. They told us what they felt was happening to them in their bodies and what we should start doing and how it would benefit them. And that was the beginning of the clinical community-based health model that we use, which actually in the clinic, we have two different types of employees that work in the clinical environment. We have the clinical staff and we have a community-based staff. And in the very beginning, we realized that we had to do some syncing up of language. We use the same language, but they may be different things. And so we had to harmonize our language. And once we got that on board, and now we're speaking the same language, we figured out how the skill sets need to come together and how we could grow, not just HIV, but we can go into all health disparities and how we can actually get patient revenue and create monies where we're not always so dependent on a grant cycle. You know, we can just be dependent on ourselves. And if the community buys into this, we're able to grow and give them more, and they're able to ensure that we stay here and that we can survive. And so it just continued to grow and grow and grow from there. And to I think 7 years later now, that was 13. We have, expanded just beyond what I thought we could have ever done. And then comes COVID. And we didn't realize that we were ready for COVID because we were set up for telehealth when no one else was. We were already doing telehealth because, again, we have other locations, but we're a small community-based organization. I can't afford doctors in every location. So we had telehealth. And so the community that we love and adore, they had access to healthcare when others may have been struggling in COVID because we were able to say, use a telehealth appointment. And we have a pharmacy, we'll mail you medication, or you can come here and we'll give it to you. So it was a good thing. I'm really proud to say what we've been able to do. And I'm even more proud to say that it came from the idea of the community and that they bought it and now we're on top of it.
Wow, this just speaks to your amazing leadership, I think. Thank you, June. And I want to stay on this topic of capacity building because this is something that Rhode Island is also focusing on. Deb, could you just briefly talk about how the department is supporting the HES collaboratives and its residents and the types of assistance and resources that you provide?
Sure. Listening to what June was saying is really exactly what we've done throughout this initiative from the beginning. We knew that we needed to provide training and technical assistance. We listened and responded to what the community was saying, what the needs were saying. And we offer sort of this platform, we call it the learning community and the training and technical assistance program. We have the learning community, a mentorship program. We're engaging in developing communities of practice, and we have individualized technical assistance and one-on-one support. And then we have our project officers. So the learning community really is essentially, it's mini quarterly conferences that came about because we recognize this need. As we're saying, we want more information. So we established a program that offers workshops, developed with the community. We engage HESs in the entire process. The state agencies, community leaders, subject matter experts. We have these regular conferences that we use as our platform for learning. We also heard sort of nurtured HES to HES mentorship program. But what we heard from the HESs is that they wanted something more formal. So we're in the process of working with a health equity zone to establish a sort of HES mentorship pilot that's really going to assess the strengths and the needs of individual health equity zones, and then create a program of support around how to build a HES. We also know that with collective impact, there's a lot of similar, we call them pillars of focus that the health equity zones have. So whether it be housing or youth engagement or seniors or maternal child health, resident engagement, we're engaging in a community of practice model right now. We've got some resident to resident meetings starting. We're working on a maternal child health cohort, which will involve health equity zone, a member of the health equity zones and Rhode Island Department Maternal and Child Health folks. And we want to start a racial equity community of practice. So this idea of community of practice, mentorship, learning community, and then we have HES project officers, of which I am. Initially, when the department first launched, the project officers were health department program employees that supported the HES while they were doing their other program work. But what we realized is we really needed to invest in this relationship, this trust building relationship. And so we've brought on, we have four project officers who are each assigned, every HES has one. These people are from the community and work directly with the HESs to help support them in their needs. And then we do a lot of one-on-one technical support from our evaluator to their evaluator, our fiscal folks to their fiscal folks, so that we can help support the project that way. It's really exciting. Again, it's that t-shirt work in progress. So it's exciting. I think that's probably the most exciting part of all of this, learning together.
Well, thank you, Deb. Before we shift gears to talk about policy, I would like to I would like to revisit this topic of looking backwards and to understand why some communities may be mistrustful of our efforts to engage them. And Maggie, this is something that you identify as one of the key challenges to effectively engaging community members. Can you talk about where this mistrust comes from and what governments, foundations, research organizations, and others can do to build and maintain trust with disenfranchised communities?
Yeah, thank you. It's been great to hear this theme recurring throughout this conversation because it's an important one. There is a long documented history of violence against communities of color, women, and poor people, intentionally inflicted by state, federal governments, healthcare, public health, and other institutions. So these institutions are built on this history, and we know it doesn't stay in the past, right? We're still hearing horrifying stories of women in immigration detention facilities being forcibly sterilized against their will, awful practices of conversion therapy for people who are LGBTQ. So institutions and governments who are wishing to engage with communities and build a deeper, more trusting relationship for the long term really must look in the mirror and reflect on those histories and the historic interactions with any given community in order to better understand how their likely new presence will be felt by the folks that they hope to work with. So discussing what it means to set goals around anti-racism, anti-colonialism, and other forms of resistance to structural oppression is super important. Institutions really must be willing to dedicate the time to support individual and organizational learning. And this is the baseline commitment that needs to be made before any outreach or interactions, requests, or inquiries begin. The time for relearning history is critical and must be built into the timeline of any organization wishing to embark on the journey of rebuilding credibility and trust with the community. You can't expect to be welcomed into people's homes or hearts without proper acknowledgement and demonstrations on how changes have already been made to mitigate future harms and breakdowns. And this is essential to do and demonstrate how you're doing this as internally to the organization and as internally as individuals. That's super important if you hope to be an ambassador. So leadership and expertise in the communities you want to work in already exists. And that's already an important thing to acknowledge. Everybody has a worldview, and the worldviews are inform the way that folks understand things. And they're likely going to be different in a community that is not a community that you come from. So work to expand your own perspectives on what's counted as legitimate knowledge versus what's dismissed is vital. Validating emotional, affective, experiential, and ancestral knowledge as legitimate and powerful is important. And acknowledging that we're able to work in tandem with other knowledge and other knowledge forms that maybe these practitioners, researchers, or advocates are bringing. So doing this can help support efforts to earn the trust of local key partners, leaders, and organizations who can often provide key insights to help you understand the local history and current dynamics. So taking the time to make these connections and earn the respect of well-regarded members of the community are critical ways to earn acceptance and understanding of the work you seek to do. And it's important to understand to compensate these individual leaders, these local community-based organizations is a really essential way to value their time and their leadership and to honor their deep experience and to hopefully begin to operate in ways that are not as extractive, maybe, right, as we talked about before. It's important to begin this, as you initiate your work, to make those positive inroads.
Thank you, Maggie. And you and others have suggested that partnering with community-based organizations may be a way to really begin establishing those relationships and building trust with communities. And June, I would love to hear your perspectives on, just real briefly, because we do need to move on. What is it? What should organizations that wish to partner with CBOs do or know about in engaging community members? And please unmute yourself.
Well, finances for one thing. I think when you think about community-based organizations, there's almost this automatic desire to underfund us. It's almost like we should just want to do the work, you know. Oh, you like all this love and passion pays our light bills. I don't quite get it, but there is this idea that we don't need as much funding, but in the grand scheme of things, we actually need more. Up until COVID, there wasn't a huge idea about what community-based organizations could do. Along comes COVID, and it was very clear that you're not going to get these vaccinations without us. If we don't go and leverage our relationships and leverage the trust that we have in community, these vaccinations are going to sit on Walgreens shelf and they're just going to be there. And so now there's this huge push to put us in, but we need to make sure we keep that momentum, that monies can flow our way so that we can actually accomplish the job. I think what entities or governments that should not do, for instance, don't write your grant for Mississippi without talking to someone from Mississippi. And there's a huge idea of you get your NOFO, you write what you're going to do, and you think these ideas are going to just automatically translate. I think that this is a shared power. We talked about that earlier. Shared power is not just me and the community, it's also the federal government and me. It's also other entities and me. I should be a part of this idea of what you want to do in the state before you roll it out and you're asking me to do things that are almost impossible in Mississippi, or they're going to just be so hard that it's going to, we may not be successful. So I think if you want us to be successful, include us in a shared power process on the very front end to ensure that what you're asking for is actually doable within the state or in any area that you're going into.
Well, thank you so much, June. Thank you, Maggie and Deb, for this terrific discussion. We will now shift a little to talk about what policy changes are needed to incorporate community engagement approaches into efforts to advance health equity. I would like to ask Amy Teverson to join us. She's the Executive Director at the National Academy for State Health Policy. Amy recently joined NASHP from the Duke Margolis Center for Health Policy, where she led work related to state COVID-19 emergency responses, including state efforts to address equity within and beyond the pandemic. Welcome, Amy. And my first question, it would be wonderful to hear your reactions to what our amazing panelists share today. What are your key takeaways?
Yeah, no, thank you so much for having me. And it was really just fantastic to hear all of the perspectives. So a couple of things really resonated with me. So I've worked with state leaders for a long, long time. I was at NGA for a long, long time, and now I'm at NASHP, and we work with a bipartisan group of states. And one of the things that really resonated with was the commonality about we really need community voices. And me working on state policy for as long as I have, I could not agree more. And I think it was great to hear Deb's discussion of Rhode Island, because we often hold up Rhode Island as one of the models for how to really engage communities with a state approach. But a lot more work needs to be done across states and really thinking about how to do this and how to achieve community level engagement. I think the other thing that really resonated with me was working cross sector. If we really want to improve health, we have to think about doing it differently, and really working across the different sectors that we all know impact our health, and making sure that there is an ability to reach across those silos and engage communities in doing that. And then the last thing I just had to say was sort of place-based. And I just wanted to put it in the context of COVID-19, what's happened over the past 18, 19 months. I'll just say from my perspective, I really think state attention on health equity is an all-time high. We've seen a disproportionate impact of COVID-19 on communities of color, and there's been a national reckoning on racism. And many states had already begun some of this work, like Rhode Island. There's other states that, have really started down this path. But I really do think it's hit a tipping point, and there is kind of a renewed understanding and acknowledgement of the ways that political, economic, and social factors, including systemic racism, impact health outcomes. And so how do we get our arms around that? And so, I do think we have a moment right now. With COVID-19, the response had to be cross-sector, right? Public health had to work with all sorts of folks. I think we realized, rolling out, testing and vaccines had to be at the community level. I think there was a renewed, we always knew this, but maybe a renewed focus on the importance of community and local strategies. And I think we shouldn't sort of let this moment pass like, oh, we're going to get through the pandemic and focus on local communities, and then everyone's going to get better and we're going to go back to the way things were. I really do think we have to understand, and I think June spoke to this very eloquently, if we want to sort of build new structures and modernize public health and bring public health into the other parts of the healthcare system, we have to build it in a way that people will want to come and trust, what we put out there from like a state or local perspective, local government perspective. One other thing I'll just say too is, we also have, historic amounts of federal funding flowing from the federal government to states and localities. I think it's a moment of great opportunity and a moment of great challenge, because it is hard for states to figure out how to spend money so quickly. And there's a lot of priorities. And I think to June's point, we really need to understand where are those really strong community-based organizations that are able to get the funding, transform it into something that's really going to be impactful for the communities. And I think the CBOs out there need sort of guidance and support to do that. And the state leaders also need some models on how to do that. So I know we can talk more about all these different aspects, but I just want to be sure I hit those topics before the next question.
Well, thanks so much for a great summary and really emphasizing some of the key points and what we've learned today. So how do we make sure that this moment doesn't pass, that this is not just something that's like a latest trend, that the community engagement approaches do become institutionalized in how we design programs and implement and develop policies and implement different initiatives to advance health equity?
Yeah. So I think there are a couple of different buckets to think about. One is, making sure you have the right leadership in state government. You really, and we've seen a couple of states really emerge with new governance structures where we have new cabinet level officials who their sole responsibility is to work on diversity, equity, and inclusion and build that across all the agencies. They report directly to the governor. We've seen this in Indiana and Washington State and Virginia, Illinois too, as well, I think. And I think you need that type of leadership to make sure that you can have a sustained focus on really building in community voices and addressing equity in all policy. So I think that's the first piece. I think the second piece is everyone needs to be really noisy, right? We need to highlight where the promising practices and, not just at the state level, at the local level, and where do we really see promise as, some of these investments are being made and, some of this work has already been done and it now paid back dividends. I mean, to Deb's credit, I think, thank goodness they had those health equity zones in place. It helped them immensely during the COVID-19 response. So as we think about, public health modernization and where we go next, make sure we're prepared, make sure we're, building back better and really recovering. We need to make sure we understand where you need to make those investments, and those need to be held up. So states have, examples to point to and models to follow. So I think those are two key pieces. I will also say that I think the community, organizational approach and the workforce, some of the issues that were talked about in workforce is also really important. I think there are different aspects of workforce. Community health workers is one piece, but really like reflecting a different way of engaging and the community and how we provide services. And it's not just, pure healthcare services. There's got to be different approaches and different ways that we actually can engage, train, and bring along different types of workers. And I'll just say this, I really think the federal government can play a really important role, and that is not just up to the states. So.
Certainly workforce development. I also want to ask about these, these culturally effective community-based organizations, many of whom may be small organizations that really struggle to stay alive. What policies or resources are needed to better support them in their work with people in marginalized communities?
Yeah, I think, and it's so interesting. I was just having a conversation with a couple of CBOs and they're like, we don't even know if we can really absorb federal funding. We're not built to have federal audits, right? We don't have the infrastructure to do that. So I think there needs to be sort of technical assistance at the state level, at the federal government level of really helping those, organizations that are really in the community really feel like they can get the funding, because funding is needed, but it's not just the funding piece. It's also how to really engage and accept federal funding and expand on the organizations. June needs to write a primer for how these other CBOs can really expand upon what they do and how to really make sure that they feel like they're in the right place to do that. So I think we have a lot of ways to go. I'll just put it that way, in getting more CBOs online to help do this work.
Wonderful. Thank you so much, Amy. I will invite the other panelists to join us now so we can spend the remaining of the time addressing some of the questions from the audience. First, a question for you, Maggie, but probably anyone can also chime in. What are the strategies to engaging members of the community who do not speak English?
It's a great question. I would say creating multilingual spaces for engagement are really helpful if you actually want to engage folks, right? And to do that, you need some dedicated resources. So that's dedicating resources to simultaneous interpretation, which can be done via Zoom, it can be done in person. And I would also consider things around if you have documents that you're sending out, whether it's agenda or something else, that those documents are translated. And certainly being able to build that time in and those resources and to have effective meetings or convenings is super, super important. And I'd also consider thinking about resources that can really help your team show up authentically. So you may be engaging with folks in a different language, but they might also have a different culture. Are there particular things that you should be aware of when entering into a space where those are the new cultural norms so that your team can be as effective as possible? The other thing I would say is that when you think about things that are more external facing, that might be your website, your social media accounts, these things may also all be in English. And so if you want your community to engage with you in these other ways, you'll want to make sure that you've got those dedicated resources and the timeline to create those social media posts that are going to be accessible to all the folks you want to work with. And then I would say lastly, one of the things that I would also keep in mind, Gina already mentioned this, like language matters, right? So we may be saying something in a way that we think translates, right? But there something can get lost in translation. So you're going to want to make sure that you're dedicated to overcoming miscommunications. You're dedicated to ensuring that everyone is on the same page. You're dedicated to ensuring that if conflicts come up because of a misunderstanding or miscommunication, that it can be handled with care and that's not kind of swept under the rug or disregarded as unimportant, because those types of interactions kind of degrade your opportunity to keep building authentic relationships in step and by sharing power with folks. And so having multilingual space where everybody can speak in the language of their heart really, really helps ensure that you're actually building that trust and creating space for everyone to participate meaningfully.
Thank you, Maggie. Okay, we do have another question, and I assume this may be for June. The question is, in your efforts to work on health equity, has there been conversations or efforts around sickle cell disease, which has a significant presence and negative impact among the Black population? But I realize this question may also be for other panelists.
No, we have not. We're really reproductive health, and then we look at the things that impact the other primary health care. We don't know what comes first, reproductive health or primary health care. So we kind of start with reproductive health and then we go backwards into primary health care. So not sickle cell per se, we've been more on the HIV, STD ends of things.
Thank you. And last question that I will put in, what are the presenters' perspectives on making the business case internally for advancing health equity and doing so using community engagement approaches? That's a tough one.
Who wants to go first? You want me to go first? I'll go first. Oh no, Deb, go ahead.
Well, I was just going to say, I mean, it absolutely makes sense. It's an economic investment in communities to flip things around the way we're doing this. We don't even know what the potential is when we start really leveraging the expertise and investing and in the lives of the people in communities. So I think that there isn't any other way of looking at it. I mean, it is a return on investment. It might be upstream a little bit, but we have to go there. I don't know, it sounds like a simple answer to a complex problem or whatever. But.
Yeah, and I would just highlight, if you look at some of the recovery plans, I think there is an acknowledgement, and it's including in Rhode Island, of, having to really invest in things like minority-owned businesses and ensuring that workers are healthy so they can go back and engage in jobs and expand on industry. And this is all economic development, right? You need a healthy workforce, you need enough folks that are interested in different types of professions, and you need to have businesses that are going to expand. And so, it's really interesting to look at all the ways that states are thinking about ARPA funds, and it aligns really with equity. So I think you can use different terms to talk about it, but at the end of the day, we're all kind of talking about the same thing.
I would say, for me in particular, from a business end, it's the best decision you can make. Public health is the community. So if you want to invest in public health, you have to invest in the community. And that could be employment, that can be bikes, trails, parks, whatever it may be, anything that improves upon them is actually going to be a return on investment. Because now they can go to the doctor, they can come to your trainings, they can learn what you want them to learn because they are better.
Thank you all. I'm afraid we're at the top of the hour. I would like to conclude by thanking our great panelists for sharing their insights, my urban colleagues for organizing this event, and the Robert Wood Johnson Foundation for supporting it. And most of all, thanks to our audience for joining us this afternoon. Have a great rest of your day.